Dear colleagues, I'm Christoph Diener from the Faculty of Medicine at the University of Duisburg-Essen in Germany. And this video deals with 4 positive studies which were presented at the European Stroke Organization Congress in Munich at the end of May 2023. This Congress was particular because it's the first time since many years that beyond thrombectomy we had positive studies. Let me start with intracerebral hemorrhage. Surgical therapy of intracerebral hemorrhage was a disaster until now. We had a number of randomized studies which were unfortunately unable to show that neurosurgery benefits for people with supratentorial bleedings like stage 1 and 2. And we even had a study with minimal invasive surgery, which had a strong trend but didn't make it. It was not significant. Now we have a new study, the ENRICH-ICH study, and this is the first positive study. This study included 300 patients with spontaneous bleeding into the basal ganglia or lobar hemorrhages with a size between 30 and 80 milliliters. And these patients were subjected to either control or minimally invasive surgery within 24 hours. The endpoint was modified ranking after 180 days. This study was positive in favor of the intervention with an odds ratio of 0.63, and this was significant from day 7 onwards. The post-operative imaging showed an 88% reduction in the volume of the bleeding. The death rate was 3.3% versus 18%, and the numbers needed to treat for mortality was 21, and to prevent severe disability was 14. And importantly, the therapy was not really effective for basal ganglia bleeding, but mostly for lobar hemorrhages. And this is an extremely important study because for the first time, neurosurgical treatment was superior to control. The next study published in Lancet was INTERACT-3, and until now we had no really convincing conservative therapy of spontaneous intracerebral bleeds except for lowering blood pressure, which showed a very strong trend in the INTERACT study, which was published in 2013 and investigated rapid lowering of systolic blood pressure in more than 2,700 patients. Now, INTERACT-3 was a cluster randomized trial done in low and middle income countries, mostly in China. And they included more than 7,000 patients in 121 hospitals. And these patients were randomized within 6 hours. So the active treatment group received 4 different therapeutic strategies to lower systolic blood pressure less than 140 millimeters mercury, strict glucose control, treatment of elevated temperature, and antagonization of anticoagulation. And this was compared to standard of care. The primary endpoint was a shift analysis of the modified ranking scale at 6 months. The patients were at on average 62 years old, 64% were men, and most of these patients were treated on neurosurgical wards. The really positive result is for the first time a significant benefit of this bundle of 4 different therapies with an odds ratio of 0.86, which was clearly significant, a numbers needed to treat of 35. There was also a significant reduction in mortality by 23% with the numbers needed to treat of 35. And most importantly, the most severely affected patients had the highest benefit. And this is an extremely important study because for the first time, structured medical treatment was superior to control in the treatment of intracerebral hemorrhage. The ELAN study published in the New England Journal of Medicine addresses a very important question, namely when to start anticoagulation in people with atrial fibrillation who had an ischemic stroke. Because if you start too late, there is an increased risk of recurrent stroke, and if you start too early, there is a risk of bleeding into the ischemic area. Now, this study was done in 103 hospitals in 15 countries, and it compared early anticoagulation with late anticoagulation. Early means that anticoagulation was initiated within 48 hours in mild to moderate strokes, and after 6 to 7 days in severe strokes. And late anticoagulation was day 3 to 4 for mild stroke, 6 to 7 for moderate stroke, and day 13 to 14 after severe stroke. The primary endpoint was a combination of ischemic stroke, systemic embolism, severe systemic bleeding, symptomatic intracranial bleeding, or vascular death at 30 days. This study had more than 2,000 patients, about a third with mild strokes, moderate strokes, and severe strokes. The primary endpoint was achieved in 29 patients, which is 2.9% with early treatment, and 41 patients, which is 4.1% for late treatment. The difference was 1.18%. Statistically, it was not significant, but there was a clear trend. Now, for recurrent stroke, the odds ratio was 0.6, which would translate to a 40% reduction in the risk of recurrent ischemic stroke, and this was statistically significant. Symptomatic intracranial hemorrhage was not a problem. There were 2 cases in the 2 treatment groups. Ladies and gentlemen, this study clearly shows that we can initiate and should initiate anticoagulation early in patients who had an ischemic stroke and have atrial fibrillation. Now, the last study is on lacunar strokes, the LUCKY-2 study published in JAMA Neurology. Remember, we didn't have a very good approach until now for secondary stroke prevention in lacunar stroke, and most probably antithrombotic treatment is not the solution, because this is not a disease of atherosclerosis. It's a disease of the endothelium in people with poorly controlled hypertension and diabetes. And therefore, this research group in Scotland said, let's try a treatment which has a benefit or which protects the endothelium. And they identified 2 drugs that are possibly effective. One is isosorbate mononitrate, and the other one is cilostazol. Cilostazol is not only an antiplatelet agent, but also has protective properties at the endothelium. Now, this was a feasibility study running for 1 year. It was open label, randomized, and they had a 2-by-2 factorial design. The 363 patients were randomized in 4 groups, either isosorbate mononitrate 40 to 60 milligrams per day, cilostazol 200 milligrams per day, a combination of the 2 therapies. The primary outcome was this study is feasible. The retention rate after 12 months was very high. What they also found, there was no reduction in a combined endpoint of vascular events dependency, but they also looked at cognition and death. And there were, in subgroups, interesting results. With isosorbate mononitrate, the rate of recurrent stroke was reduced by more than 60%, and the deterioration of cognitive impairment by 45%. And cilostazol reduced the need for long-term care by 70%. And if the combination reduced the combined endpoint by about 40%, the need for long-term care for 85%, and improvement for the quality of life of 90%. There were no safety concerns. And ladies and gentlemen, this means we have to change the way how we approach lacunar strokes. And this pilot study is very promising, and this will be followed by a properly powered long-term large trial called LUCKY-3. So, ladies and gentlemen, very exciting times. 2 new positive studies for intracerebral hemorrhage. 1 study which teaches us when to start anticoagulation after ischemic stroke in AF, and a totally new approach to address lacunar strokes. Ladies and gentlemen, I am Christoph Diener from the Faculty of Medicine at the University of Duisburg-Essen. Thank you very much for watching and listening.